All right. Well, welcome everyone to our final developmental disability rounds for this calendar year. Our next rounds will be in January, which we'll talk about afterwards. But today, as the final rounds for the year, we have a special guest presenter. So I'll be talking about a case, but more importantly, Dr. Prasad is going to talk about pyruvate dehydrogenase deficiencies. And so, Dr. Prasad, first of all, I consider myself very lucky to know Chitra. She's sort of my go-to person. If I ever have questions about neurometabolic things or stuff, she's always really helpful. But so, Dr. Prasad is professor in the Department of Pediatrics in the section of Genetics and Metabolism at Western. She obtained her medical degree from the Christian Medical College in Ludhiana, India, and did her pediatric training at the Postgraduate Institute of Medical Education and Research in Chandigarh, India, as well. She then did clinical genetics and biochemical genetics fellowship at Children's Hospital in Boston and Harvard Medical School. And before moving to London, Dr. Prasad held faculty positions in medical genetics at Memorial University in Newfoundland and at the University of Manitoba. Dr. Prasad's clinical interests include dysmorphology, pathogenesis of clinical genetic syndromes, and inborn errors of metabolism. She was instrumental in the creation of the multidisciplinary metabolic clinic and later the neurometabolic clinic at London Health Sciences Centre, and has also been the director of newborn screening at London Health Sciences Centre since 2006. Dr. Prasad has published more than 150 peer-reviewed publications and 6 book chapters on a wide range of genetic and metabolic syndromes and their pathogenesis. Perhaps more importantly, in terms of work-life balance, Dr. Prasad is an ardent fan of literature, poetry, art, and Hindi cinema. And in addition to the publication I mentioned before, she's also authored a book, which is available on Indigo for those who are interested, entitled Poetry and Emotions on Celluloid, The Role of Hindi Film Lyricists. So we are very lucky and thrilled to have Dr. Prasad here today. So Chitra, thank you for joining us.
Thank you very much. And you are our go-to person when we are stuck. So welcome, everyone. And I can't see everyone right now, but I will share my screen and hope to share this very interesting and very sad case with you all. And I agreed to give a talk because I really like Rob, and I wanted us to get some more insights into our patients' problems. All right, so the first thing I always think about any talk is what's the title? And I truly believe that this is Biochemistry to Behavior and Pyruvate Dehydrogenase Deficiency, linking metabolic defects to neurological and behavior outcomes, and it's a team approach. I just want to say that how much I love talking about biochemistry and metabolic disorders. So it was a great opportunity for me to learn again all the pathways that I simply adore. So this is, I think, Rob's slide, and this is my slide. I don't have any conflicts. So we have already circulated the objectives, and our hope this evening is to explain the importance of pyruvate dehydrogenase deficiency in neurodevelopment, to discuss the neurodevelopmental outcome of children with PDH deficiency, and then maybe touch briefly on the ketogenic diet and other treatment modalities in this very severe condition. So my story is, she is currently 9 and presented at age 4 with developmental delay, hypotonia, postnatal microcephaly. So in the intrauterine period, the head circumference was growing from the notes that I reviewed. She also had facial dysmorphisms, and I'll show you that. She had absent speech. There was a bit of ataxia, and she was initially seen by my colleague, Dr. Balchi, in genetics clinic. Her suspicion was first of Angelman syndrome because of the dysmorphisms, absent speech, and developmental problems, and some neurobehavioral issues, and microcephaly. Mom was very young, 18 years old. There was no other significant family history at the time. Parents are non-consanguineous, and she has since left that partner who was the dad of our patient. So this is a picture of our patient, and this was taken by Dr. Balchi at her assessment. And what you see over here is significant small head size. The eyebrows a bit arched. There's a bit of epicanthal folds that you see, widened nasal bridge. There's some flaring of nostrils. There's a slightly flat philtrum, thinnish upper lip, ears slightly low set, and prominent cheeks. Very mild frontal prominence, but no actual bossing. So those were some of the facial features that she had. So her weight for height kind of remained pretty low for her. But I want you to see see the head circumference here. So she is now 9 years old, and her head circumference is around 45 or 46, which is like a 1 year old, 1 year and a bit. So below -2 standard deviation. So pretty small head size. So Dr. Balchi did work up for Angelman syndrome and then proceeded with exome sequencing. And she was found to have a likely pathogenic mutation in PDHA1, which is pyruvate dehydrogenase E1 alpha deficiency. This is an X-linked disorder. The A1, there are different forms of pyruvate dehydrogenase deficiency, but this particular one is X-linked. And what she had was a likely pathogenic mutation. So the mutations are classified according to American College of Medical Genetics, and they can range from variants which are benign to pathogenic, and in between is variant of unknown significance. But when we have likely pathogenic or pathogenic, it means that the protein is getting affected and they are significant. So for the mutation in the cDNA, we noted that she has a duplication. That means there was an insertion, which led to a protein. So there was change because of insertion. And what happens when there is an insertion of, and this is just an example, you have extra nucleotides here, and 3 of them make one amino acid. So what happens is that the reading frame gets distorted and it leads to a stop. When you see an X, it means a stop codon. So that means that the protein is no longer being produced. So this type of mutation is called frame shift. So we have different types of mutations. There can be just a change in one nucleotide, which is called missense. Nonsense is, again, when there is a stop codon. And this particular type, when there is an insertion, it's called the frame shift variant. And this was seen in exon 11. So just for those who might be interested, this is actually one of the common mechanisms that we see, the duplication or deletion in females in exon 10 and 11. So this area appears to be a bit vulnerable for mutation, pathogenic mutation. We checked the mother and she did not have this change. We haven't tested the father. So this is the mutation results that were from the lab. And then Dr. Balchi contacted me and we felt that this was the correct diagnosis, which is the pyruvate dehydrogenase deficiency. And we saw her in neurometabolic clinic with our team Dr. Narayan Prasad, myself, and our dietitian, our nurse, and social worker, etc. So, where is this enzyme? Where is pyruvate dehydrogenase enzyme? And what does it do? So I'm going to make it ridiculously simple for you. And I will keep repeating the pathway so that by the end of it, it will be quite clear why this is such an important enzyme. So in a very simple way, when we take carbohydrates, which is the glucose as shown over here, it goes into pyruvate, which is a very important compound, and pyruvate goes into acetyl-CoA. So this is called the glycolytic pathway because glucose is getting converted into acetyl-CoA. And our enzyme is right here, pyruvate dehydrogenase. Acetyl-CoA then goes into the very famous Krebs cycle, the tricarboxylic acid cycle, and then into the mitochondrial pathway. So this is a very key enzyme, and this enzyme catalyzes the irreversible oxidative decarboxylation of pyruvate to acetyl-CoA. So what that means is that if you look in the biochemistry pathways, many of the pathways are reversible. So that means you can go from one side and then it goes back. But this is not going back. It has to only go in this direction. So there is a reserve of this enzyme present in our body. And if there is deficiency of pyruvate dehydrogenase, it will not go into acetyl-CoA, which is a very important, again, for going into the tricarboxylic acid cycle. So what will happen then? If this enzyme is not working, the pyruvate has no other way to go but into lactate, which is anaerobic metabolism. So we can get lactic acidosis in this condition. So right now, I just want you to focus on to glucose, pyruvate, acetyl-CoA, and the pyruvate dehydrogenase enzyme here. And that if this is not working, it's going into lactate and lactic acidosis. This particular enzyme is a big enzyme. It has many components, the E1 alpha, E1 beta, E2, E3. So what I showed you the results was of E1 alpha, which is the commonest. About 80% have E1 alpha deficiency. E1b is less common, but we do have a patient with that. That's autosomal recessive. So E1 alpha is the X-linked form that I showed you the picture of. So this is a very important and basic pathway in our body. So we're going a little further now in the same pathway. So you start from glucose, glycolysis, pyruvate, and then pyruvate needs to come into the mitochondria, acetyl-CoA here, going into tricarboxylic acid cycle, and then into these lovely electron transport chain. So the whole purpose of all this is to make these very happy molecules of ATP, which is energy. So you can see that this enzyme is important in making the energy for various requirements that we have for our body. So PDH complex is a very basic enzyme in our body and is instrumental in making ATP. It has a few cofactors. One of them is thiamine, which is vitamin B1, lipoic acid, FAD, NAD+, and CoA. So this is the glycolytic pathway, and this is where the enzyme is. You see over here, which is the PDH complex, which is active and inactive. So this is the E1, and this is where the mutation was found in our patient. So the organ that needs most energy in our body is the brain. And you can see over here how many functions the brain does for us. And for that, we need lots and lots of energy. The brain is also developing and requires a lot of energy for making the right structures. So this condition usually affects the brain. Not many other organs are affected. It's mainly the brain that takes a big hit if PDH is not working. So the clinical and biochemical phenotype can be of Leigh syndrome. And Leigh syndrome is it's more a neuropathological diagnosis, which you can see with basal ganglia involvement, developmental delay, MRI typical features, and there are over 200 genetic causes for Leigh syndrome, and pyruvate dehydrogenase deficiency is one of them. Other features, as I mentioned, are seizures, low tone, developmental delay, ataxia, and lactic acidosis. So that is, as I showed you in the pathway, if pyruvate is not going into acetyl-CoA, it will be transferred to lactate and it will cause lactic acidosis. So many years ago, we had done this review article on pyruvate dehydrogenase deficiency in epilepsy, where we had covered E1 alpha as well as PDHB deficiency. Tony and Narayan and myself, we had summarized patients with PDH and epilepsy. So you see over here the microcephaly, and I showed you the picture of our young patient. And interestingly, many of the features overlap with fetal alcohol syndrome. And I showed you some of the facial features of our patient. And the reason why fetal alcohol syndrome can have similar phenotypic features is because the acetaldehyde that the mother takes can inhibit this enzyme in the baby in utero. So those patients will have lower, smaller head circumference in utero. So how does one diagnose PDH deficiency? I think the first thing I would say is that if you, as developmental pediatricians or geneticists or pediatricians, psychiatrists, if you're seeing patients with developmental problems and microcephaly or dysmorphisms, I think it's good to get a genetic or metabolic evaluation. And you all are pretty good with that and are familiar now with our intellectual disability panels as well as microarray, exome sequencing. So it's good to have a high suspicion of maybe there is an underlying genetic syndrome here or metabolic syndrome. In terms of the biochemical features, you may have elevations in lactate. In our patient, I do not recall too much of lactic acidosis, but lactate and pyruvate both can be elevated in blood and CSF. However, the ratio of lactate and pyruvate is normal. We usually don't order pyruvate that frequently because it's not an easy assay to measure and it's not very stable. But this can be done in both in blood and in CSF. In the past, we were doing skin biopsies, fibroblast culture for PDH measurements, muscle biopsy. Nowadays, we go straight to genetics. So rightly so, Dr. Balachi did the exome and found this mutation. Another modality that helps us is cranial MRI and MRS. So I would encourage all of you when you order a cranial MRI to add MRS, which is the magnetic resonance spectroscopy, as one can measure lactate peak, One can also see creatine peak in, some of our creatine transporter or creatine metabolism defects. So this is how we diagnose PDH deficiency. The number of PDH patients is actually quite small, roughly about 500 patients in the world, maybe more now that we are using more of the genetic modalities. So what happens in the brain? I'm showing you the MRI of our previous patient with PDH deficiency because it is really dramatic. As you can see, the asymmetry here of the brain, there's a very thin rim of cortex, a lot of fluid spaces. The corpus callosum is quite thin. There's shrinkage of the cerebellum. So what you are seeing is a lot of brain malformations because the brain has not developed because of pyruvate dehydrogenase deficiency. Some more MRI images, and they can be symmetrical, they can be asymmetrical. And you see again here asymmetry of ventricles. Thin corpus callosum is quite frequently found with the pyruvate dehydrogenase deficiency. And again, you see brain atrophy, and there is also a lactate peak on MRS. So MRI and MRS are quite helpful in pointing us towards some kind of brain malformations that could be due to pyruvate dehydrogenase deficiency. I'm going to show you some videos of our patient. So here she's trying to eat, and you can see that her coordination is not that great. And Rob will go into more details about her behaviors, but she has to be in the helmet because she hits herself all the time. However, after ketogenic diet, her motor development has improved. And so here she is running around, but her coordination as well as behaviors are quite challenging. So Rob, if you want to talk about I've put your slides here.
Great, thanks. Chitra, I mean, you'll probably have to do that changing of the slides because I don't have that.
Yeah, I'll do that.
Okay, so as Chitra said, when I saw this girl, she's now 10, lives with her mother and two older siblings. So I've changed some of the information to de-identify her. But she attends a specialized educational program where it says, but because of her behavior, she's only able to go 80% of the time. So she goes 3 full days a week to school and 2 half days. But despite that, her mother still has to pick her up from school several times a week. Go ahead, Chitra. So she was referred to us by Dr. Prasad for assessment of her behavior and treatment. So just to go back a little bit, prior to 6 months, apparently her primary care physician noted that her head growth seemed to slow down. And as Dr. Prasad noted, that she was sort of referred to London, ultimately diagnosed with pyruvate dehydrogenase deficiency. All of her milestones were significantly delayed. She didn't walk till past her second birthday, and she has never used words at all. She was in a regular classroom until grade 2, and then started in a specialized education program after that. Yeah, go ahead, Chitra. Thanks. So her mother says that the self-injurious behavior began at about the age of, but 3. But she's also become more aggressive in the last few years. Because she has her helmet on much of the time, she will sort of, let me just turn on my camera so you can see. So she will bang herself in the chin a fair bit with her hand when she's upset, or on the side of her head, but also will bang her forehead on hard surfaces. Does so less when she's got her helmet on, thankfully, but there are issues with that. And when she is really upset, so more than usual, more than she would just do for bang her chin, she will bite herself on both arms bilaterally. And these behaviors happen many times a day, both at home and at school in all environments. and often precipitated by frustrations, that things not going the way she would expect or would like. So being told no, having to wait for things, having things taken away, things like that. As a result of the self-injurious behavior in her head, she wears a helmet much of the day, which is problematic for a variety of reasons. But as we'll see, she also hasn't had any behavioral intervention at this point, which is problematic. Um, uh, and what I have wondered about with other people and as well her, why at times when she's upset is she self-injurious and why is she aggressive towards others at times? And her mom doesn't know and can't really point to anything. But when she is aggressive towards others, it consists of throwing things, hitting people, and also pulling hair, particularly her mother's. So has a lot of really disruptive and difficult behaviors. Go ahead, Chitra. So as I mentioned, she was in a regular classroom until grade two and then started in a specialized program. Initially, when she started in a special ed class, she was only able to go for 1 hour daily, and that has gradually increased to the point now where she's going, I said, 3 times a week for a full day and then half days twice a week. But even with that reduced schedule, as I mentioned, her mom still has to pick her up on a regular basis several times a week. Um, the and I think not just what she's doing to herself is important, but also what the impact on her life and on her family life is. And obviously, if her mom has to pick her up, that's having an impact on her work. But also, because of the behavior, this girl is not able to attend school on a full-time basis. But also, her mother said it's really difficult to go out and do anything in the community and to engage in other activities. And so that has an effect both on the patient, obviously, but also on her family and on her brothers. Go ahead, Chitra. Thank you. She also is really hyperactive, so she is constantly moving. She cannot sit still. She's very impulsive and needs constant supervision. And her mom was saying if they go out anywhere, her mom has to hold her hand. And developmentally, I would think she's probably like a toddler, and so but just much much bigger, and so constantly has more life experience than a toddler also, and can get into far more trouble, unfortunately. Like a lot of people that we see, her sleep has also been very challenging. So with Claudine, she was falling asleep fairly well, but then, and I think Chitra, she had to wake up at 3 o'clock to take medication. Is that correct?
Um, yeah, I'm not quite sure about that.
I thought her mom said that, but I'm not sure. Anyway, she falls asleep fairly well, but then wakes up from 3 a.m. to 6 a.m. and then will fall back asleep until 7 or 7:30. But obviously, if she's awake from 3 a.m. to 6 a.m., then her mother has to be awake also, and so it's going to take a toll on her mom's health over time as well. Go ahead, Chitra. So problematically, she's never been involved with behavioral services, and I think that's something we need to really look into. We can talk with social workers about hooking them up with that. She did see a pediatrician prior in the past and was started on clonidine before the age of 5, and initially took 0.05 milligrams twice daily, but this was felt by her mom to be too sedating. So now she's only taking it at bedtime, but zero point 0.1 milligrams of clonidine at bedtime is not going to have any impact during the day. It might help with her sleep, but really won't help during the day. And she was also started on risperidone. And when I saw her a few months ago for the first time, she was taking 0.25 milligrams twice daily, which her mom said really neither of them had made much difference to her at that point. And certainly watching her, it would, well, I guess I don't know what she was like before, but there's a lot of problems still. So when we saw her a few months ago for the first time, she was taking clonidine 0.1 milligrams at bedtime, and then risperidone 0.25 milligrams twice a day. She's also taking gabapentin 100 milligrams twice a day, and then 200 milligrams at bedtime for seizures, and has been on the ketogenic diet, as Dr. Prasad said for a number of years. So in terms of her past medical history, we heard she has pyruvate dehydrogenase deficiency. She began to have seizures when she was about 4, according to her mom. But with the ketogenic diet and the gabapentin, she actually hasn't had a seizure in several years, according to her mother. Otherwise, generally healthy. So no hospitalizations, no operations. She doesn't have any allergies either. As Dr. Prasad mentioned, her parents are non-consanguineous. Her father, charitably, I think we could say, is described as having poor emotional regulation and poor impulse control. And there are 2 other siblings, and the possibility of autism spectrum disorder has been raised in one of them, as the sibling apparently has significant deficits or difficulties socially with peers. So when we saw this girl. So we can see, as Dr. Prasad mentioned, she's tiny. So her height is below the first percentile, and her weight a little bit higher, but still very low. And her head circumference is at least 4 standard deviations below the mean, so really microcephalic. With the risperidone, we wanted to check for involuntary movements or extrapyramidal symptoms, and she had none that I could see, and didn't have any tics. So she didn't greet me at all. In fact, I would say didn't really acknowledge my presence at all in the interview room at all at any point. She was constantly moving and only sat still even briefly when she was watching a video. Otherwise, she was up and down and climbing on things and walking on things and trying to get stuff off shelves. And her mother was constantly moving to keep up with her. There were a lot of toys available to her. She didn't play in any way. She looked briefly at a few, but that's about it, and didn't engage in any constructive activity. And several times ran to the door to try and leave, but was redirectable by her mom. Uh, so she didn't initiate interaction with anyone in the room, including her mother. At several points, she did start banging her chin with her hand, and there was no apparent reason. It wasn't that she was upset or frustrated, as far as I could tell. There was nothing happening. She didn't bang her head at all, as she was wearing her helmet. Uh, she didn't use any words at all during the appointment, didn't appear to be attempting to communicate really, didn't make any socially directed noises, didn't point to anything, didn't use any gestures. So really has no means of communication that I could see. There were no repetitive motor movements. She didn't have any ritualistic behavior, didn't line toys up or anything like that. But also, I think was so disorganized that she probably wouldn't be able to line up her toys and engage in that kind of repetitive behavior. So from a psychiatric perspective, I think we would say that she has an intellectual disability. Well, she's never had formal testing, and she wouldn't cooperate and wouldn't be able to do many of the things required. So I would say she has an intellectual disability, which is at least severe to profound. We can also say she has attention deficit hyperactivity disorder, although it's a different thing given her developmental level. And she also has seizures and, as we know, the pyruvate dehydrogenase deficiency. And I was looking up, and Dr. Prasad and I were talking about this briefly previously, before we started. And I was looking up trying to find out what the rate of intellectual disability is in people with pyruvate dehydrogenase deficiency. And there's very little research done on that. One small study, what they reported was about 10 to 15% of people had IQs in the normal range, so above 70. But I mean, 80% of people with it had intellectual disabilities, which compared to the general population of 1%, so it's massively higher. And among the people with intellectual disability, among this group, 10% had mild intellectual disabilities, but 57%, so almost 3/5, had either severe or profound intellectual disability. So a very disabled group of people in terms of their cognitive ability and development. Go ahead, Chitra. So, given that she was taking a fairly small dose of risperidone, the logical thing, and I asked Dr. Prasad about this before proceeding, was we increased the risperidone because there's fairly good evidence that risperidone can help with impulsive, aggressive, and agitated behavior. And so we increased to 0.5 in the morning and 0.75 at night from 0.25 twice a day. And as she was now taking risperidone on the assumption it would help with her sleep, we discontinued the clonidine. So then, if you want to go ahead, Chitra. She came back. We saw her at the end of November, I think a few days before your last appointment, Chitra. And what as a good psychiatrist I'd been able to do was make things significantly worse for her. So at home and at school, she was much more irritable. There was a lot more self-injurious behavior. She was scratching at her face a lot now. And in fact, when we saw her, there was a scratch mark on her nose. She also started screaming for no reason. And this was really, really disruptive at school, but at home as well. Interestingly, her sleep was better. But it was really her mother had left the helmet in the car when we saw her a few weeks ago, and it was interesting because she banged her head on the floor repeatedly, especially towards the end of the appointment, and she didn't do it lightly. She did pretty hard. On the floors of the hospital are pretty solid, and her mom tried to get to her before she could bang her head each time, but wasn't able to always, and so she really engaged in a lot of self-injurious behavior. But as always, was constantly moving, didn't sit still, needed constant supervision by her mom, which at times obviously makes appointments difficult if she's in the room in terms of getting information and her mom being able to focus on one thing. But she also was screaming a lot more than our previous appointment. And so really seemed to have gotten quite a bit worse with the risperidone. I don't know how or if that relates to the pyruvate dehydrogenase deficiency. But ultimately, we talked with her mom about it, and obviously, if those things were worse, we got rid of the risperidone completely, and we're going to restart her on clonidine, but at a sort of giving it 3 times a day, which it probably needs to be done in order to see benefits. And we have a follow-up appointment in a few weeks. But what really struck me more than anything was her hyperactivity and the need for constant supervision and how taxing that would be for a family and it's how much it interferes with her functioning, but also the self-injurious behavior. And I think in addition to the medication, we really need to talk with people where she lives about behavioral intervention and helping mom and things like that as well. So if, before we move on, Chitra, I just want to ask, does anybody have any questions about this girl or any comments about her? Any critics? Dr. Mitchell, welcome as always. All you have to do, Claire, is just unmute yourself.
Got it.
Yep.
Am I unmuted?
Yep.
Still asking me. Okay. Yeah. So I'm just wondering where she would get the behavior support from, because from my perspective, this is a real area where there's limited resources at the moment for individuals with severe intellectual disability and disruptive behaviors. I'd be curious, like, where is the best place to get this from and who provides it that's publicly funded?
Well, I suspect, Claire, that you know the answer to that question. And it's not available really anywhere. And they don't live in London anymore, but the city that they live in should have services, and they really don't. And even kids with autism, I mean, now the waiting list for the Ontario Autism Program is a number of years, so there's nothing. So I mean, that's a huge question. And the concern really is in this girl, we're talking about her health and her safety with her banging her head. And I don't know. I mean, that's a good question. So I think it's a goal. I don't know what we're actually going to do, unfortunately. But I think that psychologists, and I don't pretend to be one. If anybody, Allison, if you have any opinion, please correct me if I'm wrong. But I think behavioral psychologists would say that problem with putting a helmet on people then is that in order to get the sort of the proprioceptive feedback or whatever, people have to bang their head harder to get that same sensation. And so then if we take the helmet off her, then if she's used to bang her head harder, it's going to be worse in terms of potential damage, and it just becomes harder to deal with it. Actually, I guess, Claire, the person who maybe could answer your question is Allison Cox, who is a faculty member at Brock University in the Disability Studies program. Allison, do you have any opinion or thoughts about this? No, so maybe, sorry? Oh, so maybe Allison, if later on, if you want to chip in, that'd be great, because this is a huge problem and what to do with this girl, but other people with similar behaviors. Are there other comments or questions about this girl, about her diagnosis or her behavior? Okay, why don't you go ahead then, Chitra?
Yeah, I have some thoughts, and I think maybe after I finish, I will say something. So anyway, the behaviors are really very challenging, and as I've shown to you, the brain is quite severely affected. So in terms of management from our side, we have tried the ketogenic diet, and mom has done a great job of learning about ketogenic diet, and I'll show you the pathway. Cofactor supplementation has been recommended. I'm not sure for this severe disorder it will make much difference. And then, of course, symptomatic treatments for seizures, developmental support. So actually, Narayan had started the clonidine and risperidone, and initially there was a little bit of benefit, but then she started having worse problems, as Rob has mentioned. So this is the pathway again: glucose, pyruvate, going into acetyl-CoA, Krebs cycle, and then electron transport chain. Because this enzyme is not working, whatever carbohydrate you give, it's not going into energy. So in this condition, and it's one of the very rare conditions where we actually do not give extra glucose. Most of the metabolic conditions, we give them extra glucose and calories, but not in pyruvate dehydrogenase deficiency. So she has her own protocol, which reminds people not to use high dextrose or high glucose. We also caution people to check the carbohydrate content of any medications. So what we are doing is giving her ketones, ketogenic diet, which goes straight into acetyl-CoA. So that's the rationale for ketogenic diet. And then it bypasses the glycolysis completely. So ketogenic diet, the gains and the challenges. So here, this is carbohydrates, glucose, pyruvate dehydrogenase deficiency, and we are taking the ketogenic diet going straight into acetyl-CoA. So what she is on is modified Atkins diet. Mother is monitoring her urine ketones, and we are also having renal follow-up because when you change the diet, especially ketogenic diet, there are other biochemical abnormalities. We monitor her blood work very regularly, and she's not had any seizures as mentioned. So mother has moved to, I think last week or two, I did a virtual appointment with the mother. So in the ketogenic diet and PDH-related renal issues, there can be tubulopathy, metabolic acidosis, low GFR, also nephrolithiasis due to hypercalciuria, hypocitraturia, and hyperuricosuriya. So she is on citrate supplements, and Amrit has been following her for renal perspective. So genetics is very interesting. This is actually one of the disorders which is called X-linked dominant. Usually with X-linked disorders, because females have two X chromosomes, they are relatively spared in terms of the clinical symptoms. But in this condition, the females do express the metabolic disorder. And most of the females normally as well, we are all mosaics. So depending on which X chromosome gets inactivated. And as I said, about 80% are due to X-linked PDH-A1 mutation, and some due to PDH-B and other different forms of pyruvate dehydrogenase deficiency. So what you're seeing over here is mosaic. And in the brain also, that's the problem, that some cells are inactivated, some are not. That's why you see all those asymmetrical findings in the MRI and brain development. Some of the newer advances that have happened in this condition is the use of dichloroacetate. This actually has been around for a very long time, but they have recently again established the trial, and it's completed phase 3. It's like pyruvate. It stabilizes the PDH and activates the pyruvate dehydrogenase complex, and it decreases the lactate. But we don't know what happens in the brain. Newborn screening has been done in some states where they're measuring the amino acid ratios like leucine and proline. Also, the genome-based newborn screening is coming in Ontario. So I guess if we can make a diagnosis early, it might make a difference if the ketogenic diet and other management is done. So in summary, the PDH links biochemistry to neurological and behavioral outcomes, as we have shown you, and the importance of early diagnosis and genetic confirmation may help. But I have to say that none of the treatments are completely curative for this condition. But there is a lot of variability. We have some patients who may have milder phenotype and just with ataxia, some much more severe, as our patient described today. This is a very nice resource from Gene Reviews, so I've included that. I would like to end our talk with two quotes. One is by Osler. He who studies medicine without books sails an uncharted sea, but he who studies medicine without patients does not go to sea at all. And this is very true. So it's the patients that teach us everything that we know. And this is my favorite quote: to cure sometimes, to relieve often, and to comfort always. Um, so yes, we cannot cure, but I think the family definitely needs support, because I don't think they will be able to carry on too long. Um, and I definitely feel the frontal lobes are affected, and um, we have some other metabolic disorders which cause a lot of self-mutilatory behaviors like Leishman syndrome, although those patients are quite intelligent, but they can have very significant self-injurious behavior. But with her, like, it's very hard to be in the room for even half an hour with her. So I just worry how long the mother is going to last with this. She's moved to her because the neighbors were complaining, and every time, as Rob mentioned, like, she has to go to school to pick her up. So I believe she has more family support, but I'm not aware of what other services can be placed. So happy to take any other questions.
I mean, thank you, Chitra. That was a fantastic review. Just to add to what you were saying, I talked with the mom about this the first time I met, that even though she was only 18 when she had the patient, her mom actually is really well organized and has got her stuff together very nicely. And I was really impressed, given that sort of the amount of traveling she has to do back and forth from her work and things. But it is difficult, I think, to watch anybody with severe self-injurious behavior is difficult. And I've thought about it from a parent's perspective. It's also pretty devastating to watch your child hurt yourself in that kind of way. And I think Carrie Charters has been involved with them in the past. I don't know what they have where they live. That really is the is one of the problems. So there were a couple of comments. So first of all, and I apologize, I'm assuming I'm going to butcher your name, but Pratibha Bai had asked if, in terms of behavioral stuff, if this could be picked up by NBS. I don't know for sure what NBS is. I wonder if that's Niagara Behavioral Services. And I think because this girl lives in, well, much further south, and I would doubt that would be in their catchment area, but it's something to think about. Um, and then Allison Cox, who I mentioned earlier. So unfortunately, began. So Allison suggested something like contact Hamilton for resource, but there is the John
Or the
McGivney Center, which
McGivney Center. I don't
yep,
know if they take 9 years and 10 years old, because
yeah,
that's what would help, like some kind of very
yep.
intense, um, you know.
Yeah, and I think what Allison suggested, I think it's probably a good place to start, be some kind of case manager through community living, Essex County, or something like that, just to help mom negotiate the system, even for things like respite care and summer camp and stuff like that, because she has to be busy. Um, and I think again, Allison's point is well taken about the about special service at home for respite care. I think would be great. So there was a couple of people with their hands up. Bilal Salem, I will allow you to talk. You just have to unmute yourself.
Yeah. Hi, are you able to hear me?
Yes.
Oh, thank you both for this wonderful talk. I just wanted to clarify, this is a common, I deal with, like I work with Dr. Prasad on adults with metabolic disorders. So I have been seeing a lot of patients, and I imagine that their childhood was not very easy. And what is the proper answer for both of you that you will respond when they are asking why us? How do you deal with this question? Like with the statistics you're showing, this looks to be a very rare anomaly, and the description looks to be 1 in 100,000. So I know some people has belief system and they can relate that this is a test from God or something, but like it's really very hard. And this is something that I'm commonly hearing from adults who are in their 20s or 30s with metabolic and genetic disorders. So how do you approach that? Like, why did they have that? And the other question would be, is there any bright side of that? Because like people with bipolar disorder or schizophrenia or autism spectrum, sometimes, like the sevens and the creativity and the high energy that can come with those disorders I'm not sure. Is there anything bright or something special on those kids that we can inflate or make the family aware of that can at least decrease their suffering?
I'm just going to first of all say hello to you, Bilal. Thank
Sorry,
you so
yeah, I
much.
cannot open my camera, but yeah, I'm happy to see you for the first time.
Yeah, I know, but I am so appreciative. I can't tell you how much I appreciate you and Rob, because it's a team, as you know. So I think what Pratibha was asking was newborn screening, if I understood right, if it's NBS. Pratibha, I mentioned about newborn screening that some places they have used amino acid ratios to check in the newborn, and also the genome screening is coming,
No.
so we should be able to pick up. About your question, first of all, the guilt part, that is very real. And whenever we are talking about X-linked conditions, even though this is a de novo change in her, it's a very big thing to address. And I try and sort of always say that these are changes that happen, but like you're not to be blamed. So we go through all that. But it's a big problem with all the genetic and metabolic disorders. In terms of psychiatric things, I think it's a very good point that you've raised. And I was wondering, is there something like antipsychotics other than, risperidone that we can use? Because she, we have to remember that it's a different way that the brain is expressing the. So maybe there's an exaggerated the neurotransmitters are like, we haven't measured our neurotransmitters. We do not know what's going on in the brain. I have shown you a lot of the biochemistry and the energy part, but what's happening to all the neurotransmitters? I'm sure there's a lot of dysregulation. So I don't know if it's a possibility to just slow her down a little bit. um,
Well,
I don't know
I
what you
think
think.
that's sort of the goal, right? I think, unfortunately, in psychiatry, I think I can say, I guess it reflects my opinion only, but we really don't know how these medications work at the end of the day. That, I know, for example, that antipsychotics reduce the symptoms of schizophrenia, and I know that they block dopamine receptors, among other things, but we really don't know why blocking dopamine receptors reduces the symptoms of schizophrenia. And and I think that's sort of the holy grail, right? Is to figure out how do we target some treatments to individuals. So there are many, many antipsychotics with all slightly different binding profiles. And so that would be the question. If the clonidine doesn't help her, then I would think about something like aripiprazole or something like that. But that's really trial and error, I suppose, at some level. And what can help. And I think, some are more sedating. So if we give it at bedtime, if she's having problems sleeping, might help her to stay asleep. And some may help more with hyperactivity, but it's really targeting. And what I'll often say to parents, what is the biggest problem? Is it, the hyperactivity? Is it the lack of sleep? Is it the self-injurious behavior? And let's see if we can target that first. I think one of the real problems with self-injurious behavior relative to aggressive behavior is that I think it's often going to be inadvertently reinforced by people because nobody wants to see somebody banging their head or hurting themselves. And so people will often give kids doing that something just to stop them from doing it. But unfortunately, that inadvertently reinforces it and perpetuates it. So it's really hard. Um, the question about how do we tell people, I think people more often ask me about prognosis, I suppose, but sometimes people ask about, why. And I think ultimately we have no, I mean, it's random chance, I suppose, essentially. But I think we all, at some level, want to believe that the universe is a very orderly and structured place where there's a cause for everything and an effect for everything, which is not the reality of the situation, but I think we all would like to believe that. And I think we always want to know the answer to the question why, but I really assume there isn't one, unfortunately. Uh, the and which makes it really difficult, I think, for families. I think when you were saying you were worrying about blaming in psychiatry in particular, we have a terrible history of blaming parents, and not, frankly, even parents. It was always mothers. The spin I used to put on people is, at least according to the old time psychoanalysts, mothers were thought to influence their kids' development, perhaps badly, but at least they were an influence. Whereas fathers, I think, were a complete afterthought. We had no impact whatsoever on our children's development. We were irrelevant for the most part. But it is a very good question. I was thinking with that, though, Chitra, with the question of, people ask why. What is the prognosis generally for people with pyruvate dehydrogenase deficiency?
Not great.
So life expectancy?
um, See, the thing is, whenever the heart is affected, then you can sort of predict, but mostly with just the brain, we can't predict that. I mean, she's not got a G tube,
Yep.
but it depends on what the feeding will be like and things. So um, it's not like life limiting within a few years, but it could be, in teens and things like that.
Okay.
One of our patients with PDH deficiency, the first MRI that I showed you, she lived for about, I think, 19, 20 years because mother was having a ICU at home. And she had all kinds of photocath and everything. So of course, the more you put in a lot of medical interventions, then they can survive. But the quality of life, especially in our patient, is pretty challenging. And like you said, I am very impressed with the mother that she's actually managed to finish some secretarial courses,
Yep.
and she's doing her best.
Oh, yeah, I think given her own personal history and background and her age, it could have been a disaster. And I think what she said, actually, she told me was she realized when her daughter was born, but it was diagnosed with this, that she had to get her life in order because that her daughter would depend on her forever. So I was really impressed with her and what she was able to do. Dr. Goldberg, you're next in line. If you would like to unmute yourself. And then Julio after that.
Can you hear me now?
Yes, sir.
First, I'd like to congratulate Dr. Prasad. That was a beautiful demonstration of how metabolic disorders work. And just a few little historical notes. There is a bridge between CPRI and your lab. Dr. Gatfield was the individual who developed our metabolic service. And then later on in years, Tony Rupar came. And now I see that Tony is now working with your lab. But I would say you gave a beautiful presentation of how metabolic disorders work, all the way from Gerard when he originally discovered it about 1900. And we did have a visit from Dr. Guthrie at CPRI in my time, who developed the screening for PKU. But the CPRI did transfer the metabolic service over to Children's Hospital, and it's nice that Tony was that bridge. In terms of therapeutic interventions, Rob, I wonder why not consider a CNS stimulant for her? She's probably quite deficient in dopamine and norepinephrines, and why not try a CNS stimulant? Okay.
I mean, I think, Ben, that's a really good question. I think that, I think as I learned from you, the lower you go in IQ, the less effective stimulants tend to be. But when they work, they make a huge difference. I think the two issues, one would be around her sleep, which would be problematic. But I think for now, her mother felt that the self-injurious behavior was more of a problem. But certainly, that thought had crossed my mind as well. And that actually at our next point will be something to talk with mom about. On a sort of similar but unrelated note, so I think, well, that doesn't make any sense. But so sometime next year, and I'm not sure when, but there's a neurosurgeon in Toronto who has done a trial for people with really severe self-injurious behavior of deep brain stimulation. I think puts the electrodes in the caudate, if I'm not mistaken. And he's going to do our rounds in sometime in the new year. But he has published a trial of, I think, 10 or 11 kids in Toronto with severe self-injurious behavior. And with deep brain stimulation, I think 6 or 7 or something like that, I don't remember the exact number, had a significant improvement and reduction in self-injurious behavior. And one of my patients was involved in that, and his parents say it's been life-changing for them, really. So certainly there are newer options coming out. Obviously, with sticking electrodes in somebody's brain, we have to be very careful and a very select group of people. But I think that's something that is emerging.
So, I mean, I think that would be something I would say we can think about, because the problem is seizures have not been a major problem with her. Lactic acidosis has not been a major problem with her. And ketogenic diet, for what it's worth, has actually stabilized some parts of her care. As you saw, the motor system is working. So I think trying the deep brain stimulation might be something to go for, because we have to, as you said, like what medications are you going to try? You have to then give them in a very, I'm going to give it for 1 month, see what the outcome is, and change, because we don't know what's happening with the neurotransmitters.
No, and I really believe that ultimately the most important form of intervention is going to be behavioral, but it's not easy to access, unfortunately. And these things all take time. And even with medication, if she is let's say just hitting herself 100 times a day, just because it's a nice round number, even if medication reduces that by 90%, you're still talking about a number of times a day where she's potentially harming her brain. And so if there are other more specific interventions like deep brain stimulation, if it turns out to work well, I think it'll be fantastic. Dr. Soto-Santi, if you would like to unmute yourself, we'd love to hear from you.
Hi. I actually know this patient. I think
Yep.
I sent this patient to Genix. I guess what I was wondering is, especially now that she's a bit older, and I know there's been a few transitions, because I think she had moved from another place to here and then to, and
Yep.
wondering, would you ever consider an SSRI for her in terms of, I know she's delayed, but could there be an anxiety component, and would that maybe help with some of the behaviors?
So that's a really interesting question, Maria, because what I've discovered, I think, over time is so most people who get referred to us here at CPR, I think it's largely because of externalizing disruptive behavior, not anxiety. But what I've really been surprised to learn over time is how many of those kids have some significant anxiety underlying the externalizing behavior. That it's not what brings those kids to anybody's attention, because people don't get sent home from school because of anxiety, right? It's all the other behaviors. But certainly, I don't know that her mom has described any anxiety. And well, given that it's difficult to talk with mom because of her daughter's behavior, and so the next time I see her, we're just gonna have a phone appointment, so it might be easier. So it's a really good question to ask. I mean, in general, there is no good evidence that SSRIs help with impulsive, agitated behavior, unless there is anxiety, which is directly related to those behaviors. So if there is anxiety, I think it'd be certainly a reasonable consideration.
Okay, thanks.
Yep. Thank you, Maria. That's a really good question. There were also a few questions in the chat here I can try and ask. So Dr. Martinez Trujillo, Professor Dr. Martinez Trujillo had a question about deep brain stimulation, but I apologize, Julio, I stole your thunder, I suppose. Are there any other comments or questions? I mean, it's a really interesting topic, and it's nice, ideally in the future, Chitra will be able to take, as you said, like from brain and biochemistry to actual behavior and then treatments. That's sort of our goal for everything. Not sure when that'll happen, but that'd be fantastic if we could understand these things better and then have much more specific treatments. Because they said the quality of life and then the lost productivity from things is huge for societies, for all of us, not just the family. Okay, so if there are no further questions, so we wrap up with a couple things. So our next rounds are on January 14th, and Dr. Pamela Block from the Department of Anthropology, who we're talking about, her title is From Kinship to Care, Comparative Autoethnographies of Sibling Worlds in Canada and the United States, talking about sibling experiences of disability in family members and aging in particular with siblings. And then there is also further information on our website, which is ddp.uwo.ca. And we have our annual spring CPD on April 16th at the Ivy Spencer Leadership Center, which will include lunch. And we have three presenters. So Dr. Marina Ibarra from Victoria Hospital is going to talk about assessment and treatment approaches to children and adolescents with obesity. Dr. Jennifer Barr from the Department of Psychiatry is going to talk about sleep disorders in people with developmental disabilities and approaches. And then Joan Gardner from CPRI will talk, also do a presentation about speech and language disorders in children and adolescents and what we should be looking for and how we recognize them. So we hope to see everybody at those events. But just in closing, Chitra, thank you again. This was fantastic and really it was eye-opening for me. It provided a huge amount of information. So I really appreciate that. And I think I can speak for everybody else in saying it was fantastic. So thank you very much for joining us.
Thank you very much. Nice to see all of you.
Yep. All right. Take care, everybody. Have a wonderful holiday, and we'll see you all in
Bye-bye.
2026.